Surgery of ear, Glasscock and Shambaugh surgery. Chapter 28, Tympanoplasty, Tympanic membrane repair. Effects of tympanic membrane perforations on hearing. In patients with tympanic membrane perforations, the round window begins to play a more active and troubling role in the mechanisms of hearing. Tympanic membrane perforation removes sound protection from the round window with a tendency for sound to reach both windows at nearly the same moment, thus cancelling the resultant movement of the perilymph. As long as the transformer ratio of the middle ear is larger, as in the case of small tympanic membrane perforation with an intact ossicular chain, the cancelling effect of the sound reaching the round window is small. As the perforation enlarges, the transformer ratio diminishes. The cancelling effect of sound on the unprotected round window rises rapidly until a total perforation results in a loss of 40 to 45 decibel. An interruption of the ossicular chain does not add much to the hearing loss of a large perforation. However, behind an intact tympanic membrane, it results in maximum conductive hearing loss of 60 decibel because both windows are protected from sound and there is no sound pressure transformation for the oval window. The ideal tympanoplasty restores sound protection for the round window by constructing a closed and air conditioning middle ear and rebuilds the sound pressure for transformation mechanism for the oval window by connecting a large tympanic membrane with the stapes footplate via either an intact or reconstructed ossicular chain. Etiology of tympanic membrane perforations. Tympanic membrane perforations results mainly from infectious and traumatic etiologies. Infectious etiologies. Perforation resulting from acute otitis media heals spontaneously in the majority of cases. However, in rare instances, a central perforation may remain, especially in cases with associated eustachian tube dysfunction. Acute otitis media, secondary to group A beta hemolytic streptococcus, is associated with a higher incidence of tympanic membrane perforations and mastocytitis. Chronic otitis media with effusion treated with ventilating tubes can result in tympanic membrane perforation, atrophy, retraction, hearing loss, and tympanosclerosis. Typical temporal bone pathology findings in chronic otitis media with tympanic membrane perforations include granulation tissue in 97.4%, ossicular changes in 90.5%, tympanosclerosis 19.8%, cholesterol granuloma 12.1%, and cholesteatoma 4.3%. Perforation secondary to tuberculosis otitis media are rare and diagnosis is made with a positive middle ear tissue biopsy for acid fast bacilli and a positive mycobacterium tissue culture. Significant clinical features are pale granulations in the middle ear, disproportionately severe hearing loss, facial paralysis, the presence of normal mastoid cellular development, and a past or family history of tuberculosis. Antituberculous treatment and surgery give good results. Traumatic etiologies. Traumatic tympanic membrane perforations result from penetrating trauma, non explosive and explosive blast injuries, and iatrogenic causes. Decreased hearing, tinnitus, and oral fullness are common initial symptoms. Persistent dizziness or disequilibrium and tinnitus should alert the physician to the possibility of concomitant inner ear injury and may prompt inner ear exploration. Thorough otologic, neurologic, and auditory audiologic evaluation is imperative for detection of any associated perilymphatic fistula. Inverted perforation edges displaced segments of tympanic membrane in the middle ear cavity and foreign bodies. For patients with inverted edges under local anesthesia in the office, a piece of sterile gel foam soaked in saline is placed into the middle ear through the perforation. The edges of the perforation are then everted and a properly trimmed piece of gel foam or cigarette paper is placed on the tympanic membrane. Oral antibiotics are prescribed for 1 week if for water or foreign body has entered the middle ear. Patient is advised to avoid blowing the nose, take water precautions, instill ofloxacin autotic ear drops twice a day, and return to the office in 3 to 4 weeks for re-evaluation. Penetrating tympanic membrane injuries are usually self-induced and are secondary to cotton-tipped swab injuries, bobby pins, and other objects used to relieve itching or clean the ear canal. These perforations usually heal spontaneously within 4 to 6 weeks, and during this period, patients need to observe water precautions. Penetrating thermal injuries, such as hot slag, carry a poor prognosis regardless of medical and surgical treatment. Facial nerve injury and sensorineural hearing loss have been reported as a result of welding sparks. Other causes include water activities such as skiing and lightning strikes. Patients with perforations resulting from water activities are at a risk for developing otitis media and should be treated with non ototoxic antibiotic drops such as ofloxacin or TIC. Non-explosive blast injuries include entities as a blow to the ears, usually a slap, which results in a sudden increase of air pressure that ruptures the tympanic membrane. It has been reported that conservative management of non-explosive blast injury tympanic membrane perforations result in spontaneous closure in 94.8% of cases. High frequency sensorineural hearing loss has been detected in 20% of these patients. Healing of the perforation is always associated with closure of the air bone gap, while recovery of the sensory neural hearing loss is less frequent. On the contrary, in a report of 124 tympanic membrane perforations resulting from explosive blast injuries, only 47 healed spontaneously. Early intervention with eversion of the perforation edges and the application of paper patch has been recommended for these cases. In a recent report regarding 541 blast injury victims of the coalition forces in Iraq who underwent neurootologic examination, 35.2 were found to have tympanic membrane perforations. In 37.8% of cases, perforations were bilateral. Approximately 37% of the shoulder soldiers reported wearing ear protection, a precaution that was associated with a significantly reduced risk of tympanic membrane perforation. In such cases, displaced tympanic membrane remnants in the middle ear cavity should be detected early on and be removed in order to avoid cholesteatoma formation. The most common iatrogenic perforation results from ventilation tubes for otitis media and have been reported to occur in 4.6% of the patients following tympanostomy. Perforations rates are higher for tubes of larger diameter and with those with longer retention times. In a study comparing T tubes to small grommets, the Donaldson tube, the perforation rates were 13.6% and 1.8% respectively. Gel foam or gel film patches of the perforation at the time of ventilation tube removal has decreased the perforation incidence. Perforations following exploratory tympanotomy for stapedectomy and other middle ear pathologies are rare. Goals and expectations of tympanoplasty. The two goals of tympanoplasty are to achieve a dry ear by eradicating middle ear disease and hearing improvement by closure of any tympanic membrane perforation by grafting and or oscular reconstruction. The results of tympanoplasty are measured in terms of success or failure of graft stake and hearing improvement. In order to obtain a fair assessment of the long-term success of ear surgery, it is best to separate cases of benign central perforations from cases with cholesteatoma, previous tympanoplasty failure, severe mucosal disease, poor eustachian tube function, and total loss of the ossicular chain. Individuals with benign perforations and simple ossicular chain deficits have a good to excellent chance of obtaining a dry ear and hearing within a normal range. Such a patient may expect 93 to 97 percentage of chance for a graft take and 85 to 90% chance for a hearing gain to within 20 decibel of bone level. It must be remembered that the tympanoplasty may be considered partially successful if dry intact ear is obtained regardless of whether there is any hearing improvement. Patients with atelectatic ears and poor eustachian tube function undergo tympanoplasty may be benefited by inserting a long-term ventilating tube. Indications for tympanoplasty. Indications include tympanic membrane perforation and associated hearing loss with or without middle ear pathology such as tympanosclerosis, small retraction pockets, and cholesteatomas. Contraindications for tympanoplasty. Absolute contraindications for tympanoplasty include poor general health, malignant tumors of the aorta or middle ear, uncontrolled cholesteatoma, unusual infections such as malignant otitis externa, and complications of chronic ear disease such as meningitis, brain abscess, and or lateral sinus thrombosis. Tympanoplasty is also contraindicated on the only and significantly better ear in order to avoid risks of irreversible sensorineural hearing loss. Operating on the better ear in a patient who can use a hearing aid in the opposite ear with satisfactory results may be considered in selected cases. Any acute exacerbation of chronic otitis media, chronic mucoid discharge, associated with allergic rhinosinusitis or chronic otitis externa should be controlled with appropriate treatment prior to tympanoplasty. A non-functioning menstruation tube is a relative contraindication to tympanoplasty, although this is not always easily determined preoperatively. Smoking has been reported to be significantly negative prognostic factor and has been associated with threefold increase in long-term graft failure. Indications for tympanoplasty in the elderly and children should be individualized. With modern aesthetic techniques, the older individual in relatively good general health can be operated on without any significant risk unless there is a chorosteatoma or bilateral tympanic membrane perforations with significant conductive hearing loss. Tympanoplasty in children can be delayed until the age of 8 or 10 when the incidence of otitis media decreases and a satisfactory outcome is more likely. When surgery becomes necessary in young children, the author prefers using cartilage shield grafts, which are resistant even to continuous eustachian tube dysfunction. Hearing aid fitting is another option for such cases. History of recurrent otitis media or presence of otitis media with effusion in the contralateral ear are suggestive of dysfunctional eustachian tube and should alert the otorhinolaryngologist to the possibility of poor surgical outcome. Repeated surgical failures due to extensive middle ear fibrosis or a non-functioning eustachian tube, recurrent perforations, and prosthesis extrusion are better left alone. The patient should be given option of a hearing aid, although the recurrent ear drainage may be a major problem. The Baha system has provided satisfactory result for patients who cannot tolerate conventional hearing aids due to recurrent otitis externa, draining mastoid cavities, and active chronic otitis.